Okay.
So, hi, Ben. I'm Bill Peckham. I'm the publisher of Dialysis from the Sharp End of the Needle. And why don't you introduce yourself, Ben?
Sure. My name is Ben Hippen. I'm a general and a transplant nephrologist at Metropolitan Nephrology Associates in Charlotte, North Carolina. I'm a transplant nephrologist at Atrium Health in Charlotte, North Carolina, used to be known as Carolina's Medical Center. And I've been in private practice for the last 13 years.
So, a transplant nephrologist, your practice specializes in following people through the process, basically? Is that
Right. So I'm both a general and a transplant nephrologist. So I'm an attending physician and a medical director at an in-center dialysis facility as well as a home therapies facility. But most of my clinical responsibilities have to do with evaluating patients for listing for transplant, evaluating living donor candidates, taking care of patients immediately post-transplant, and long-term post-transplant care.
right? All right. Well, good. You might be the first person I kind of met through my blog. It seems like most of my commenters were people I already knew, but you were a very early commenter. I always enjoyed your feedback. We didn't always agree on some of it, but it was always very civil. So, but today, I'm happy to talk about organ procurement and things, but kind of this was triggered by you just had an article in the American Journal of Transplantation. Unfortunately, it's the whole article isn't available, but in general, I'll let you describe it. But it talks about integrating transplant and CKD care into a CAC, a CEC, and which is a cost control model, I guess.
Of sorts, yeah.
What was that?
Of sorts, yeah.
Yeah, of sorts. So I probably didn't explain that very well, but your I think your goal of the article was to get into this omnibus budget bill that just passed last week, and I think generally people feel like there's not going to be another vehicle for those changes. But can you describe the what you were advocating, and I think that'll
Sure.
give kind of a roadmap to where you think where it should go. Maybe sorry,
Sure.
but just give a general background on just the overall effort. I know CEC led to the ESCOs, but I think CECs were first, so we'll start there.
Right. So the general idea behind the paper was that transplant centers, nephrology practices, and dialysis facilities don't communicate very well with one another. They sort of live within their own autonomous silos. They are interconnected, but it's very regionally, locally dependent as to how well they work with one another. And in terms of making sure that all patients have all options readily available to them, it just struck me that the best way to do that is to try to find ways to eliminate these silos or break down these silos. And so the general idea behind the paper was how all three of these entities can coordinate to make sure that all patients have all options available to them, that they have a solid educational foundation on each of these options and access to each of these options in a way that makes sure that clinical information is seamlessly transmitted across all of these different entities. I can't talk too much about ESCOs, mostly because I'm not allowed to. I'm in an ESCO. And Medicare is very picky about what I can and can't say about
I'm on an
ESCOs.
ESCO
But
board too. So.
there you go. So, but the general idea was, but when ESCOs came along, this seemed to me to be a reasonable vehicle to piggyback on to
We should
try
just
and break
say,
down.
before we get too deep into the acronyms
Sure.
and initialisms,
Oh
ESCO is
yeah.
End Stage Seamless Care Organization. I'm not
Right.
sure what a CEC is. CEC?
That's a comprehensive ESRD care
Yeah,
model.
care model. So, but just the general impetus to this is the idea that I've talked a lot about historically, that this idea that there's a Part A and a Part B Medicare and a Part D Medicare now, and that by combining the total Medicare spending under all three of those programs, or at least the two programs, A and B, that you would better be able to control costs.
Right. So the general impetus behind the ESCO, the ESRD Seamless Care Organization, is to try and create models of care coordination to both provide quality care for patients, eliminate unnecessary expenditures, and in fact, the financial model behind the ESCOs is shared savings. So, assuming you take a group of patients and are able to provide quality care measured in some objective fashion, on some raft of quality metrics, if you can do that and do it less expensively compared to a historic Medicare cost baseline, that the government and the members of the ESCO can share in the savings in some fraction. Since transplantation as a therapy is less expensive than most dialysis modalities over time, the first year is more expensive, but after about 14, 18 months, depending on what cost assumptions go into it, a functioning transplant is cost savings compared to most dialysis modalities. The idea would be if you could integrate a transplant center into an ESCO model and provide a historic cost baseline for a transplant compared to providing dialysis, that would actually provide a financial incentive to increase the total number of successful transplants. This would also give transplant centers a financial hedge. So let me explain. When transplant centers do organ transplants from higher risk deceased donors, what used to be called expanded criteria donors, they're now called high KDPI donors. These are kidneys from donors, yeah, right, KDPI, Kidney Donor Profile Index. Basically, older and sicker donors. Those kidneys typically take longer to work. They have higher in-hospital costs and more complications. But, on the whole, they do tend to work and confer benefits in cases where they do work. But they tend to be more expensive. The transplant center is typically for Medicare primary beneficiaries
to get the person through the process. Is that what we...
Correct. Yeah. So those additional costs are typically not reimbursed for patients whose primary insurance is Medicare. We're not reimbursed as much as they actually cost. So for transplant centers that do a lot of these higher risk organs, they tend to lose money on those organs on average. So that creates a modest financial disincentive for centers to perform those transplants. But in an expanded ESCO model that would include the transplant center, increasing the total number of transplants could realize more cost savings compared to some, say, 3 years of dialysis. If you compared 3 years of dialysis
which is
costs
the Medicare coverage period.
Right. You could realize cost savings from doing organ transplants, even from these higher risk and more expensive transplants, thus financially incentivizing all three of the partners to do more higher risk transplants and offer a financial hedge to transplant centers that might be losing money on those individual higher risk transplants, but could make up the difference when they're sharing in the savings from doing more transplants compared to having more people on dialysis. But none of that's to say, though, Bill, that transplants is not necessarily the right answer for everybody. You and I think, agree on that.
Yeah, we know it's but it's a great solution for a lot of people, for many people, and I think your interest, clinical interest, often focuses on the preemptive transplant, and now the challenges of getting that for someone that doesn't have a living related donor with the new UNOS rules and things. So, but I guess one question I have, just technical maybe, is that the transplant center isn't the organization at the center of these cost control organizations, right? I mean, they're a partner in it, but most of the savings I mean, it depends how it's structured, I suppose.
Yeah.
But
Well, under the current structure, there, as far as I know, there are no transplant centers that are partners in any of the current ESCOs.
right.
But my idea, and in fact, patients who are currently enrolled in an
So
ESCO,
would
if they get transplanted,
I was just going to say
if a patient,
what you were advocating for, sorry, was to allow transplant centers to participate. Is that
yes,
that's the good way?
because right now, patients who are ESCO enrollees who get transplanted get unenrolled from an ESCO. My proposal is to keep those patients in an ESCO so that the cost savings from getting them transplanted can be realized by the ESCO partners, and then bringing transplant centers into the ESCO as a third partner.
Okay. Yes. The goal is that as the number of people that can have a transplant and want to have a transplant get a transplant. I've been talking a lot about patient-centered, the term patient-centered, this idea. And so I'm kind of wondering, so what does patient-centered mean in the context of transplant? And I'll say, like, for instance, just to take my own example, living by yourself is not something the transplant centers want to hear, because post-transplant you need, care. They want someone looking after you, really.
Sure.
At the same time, people who live alone, we're independent. We're used to having to make do by ourselves. There's, you could look at the CDC even. There's a certain element of risk to living alone, it turns out.
Sure.
That's true for people who use dialysis or have a kidney transplant. But so how does that that seems like a point of friction. So just to take one where we could say patient-centered, and what would that mean? And I hadn't really thought about it, but then I guess it's the financial risk to a transplant center, or why is the transplant center so is it acts as such a gatekeeper? If people smoke, or I don't know, I'm not sure of all the reasons you can get flagged, but
Yeah. So let me start with your first point about patient-centered care with regard to transplant and relative and absolute contraindications to transplant, if you like. One of which being not having quote-unquote social support, which I think is not the same as living alone. Plenty of people who live alone have social support. To my mind, that's if that's taken to its extreme, I mean, that's using some sort of clinical criteria on a piece of paper and not applying it to individual patients. That's what a multidisciplinary transplant team is supposed to do. A social worker and a nephrologist are supposed to ascertain what the specific circumstances are of an individual patient. And I think that living alone per se is not a contraindication to transplantation at all. It's not in my center. There's lots of different things that people can do, friends, family, what have you, but certainly we transplant lots of people who live by themselves. The issue is just making sure that, particularly in the early phase after the transplant, that a person who's suffering a complication that needs to be attended to immediately, we have a mechanism to deal with that. But look, home dialyzers have pioneered this. I don't have to tell you. I mean, solo home hemodialysis therapy is probably the template for how this could be done in the transplant setting. So from my vantage, that's not a contraindication to transplantation at all. The second point with regard to transplant centers and risk aversion is kind of a longer story. It's a result of sort of how transplant regulation has evolved over the last 10 years or so. Back in the mid-2000s, there was a move from HHS to really try and increase the total number of organs procured at all the different organ procurement organizations. There was this argument that there were a lot of potentially procurable and transplantable organs that were not being used by transplant centers and that they really should be. So there was a move toward that through the Organ Donor Collaborative. Then what happened was Medicare became much more interested and much more focused on transplant center outcomes, and in particular, sanctioning programs that fell afoul of risk-adjusted expected patient survival and graft survival. And as a consequence of that, transplant centers became much more risk averse with regard to taking risk on patients with additional comorbidities, especially comorbidities that were not well measured in the risk adjustment models that CMS was looking at.
These are maybe comorbidities you as a nephrologist would identify, but CMS isn't identifying, basically.
Correct. So the classic example is cardiovascular disease. So people who have multivessel coronary artery disease clearly have risks with regard to the perioperative and immediate postoperative features of the transplant. But that's not in the risk model, in part because nobody can fully agree on what cardiovascular disease really is. And there's a worry that transplant centers may take a very liberal view of what counts as cardiovascular disease to improve their risk adjustment. That is, to some extent, game the risk-adjusted system so that they don't fall afoul of patient graft survival benchmarks.
So, I just have a question. I'm not. So is that a curve? Is there some percent that's always, being identified as below the mean? So, if there's, or is it just a threshold that everybody can get above the threshold?
Well, so transplant centers submit data on patients, on all their patients on the waiting list. And every 6 months, the SRTR, which is the Scientific Registry of Transplant Recipients, the keeper of the data, if you like, gets data from all of the transplant centers for a long list of patient variables. And then they take those variables and they crunch the numbers, and every 6 months they put out a new list of risk-adjusted variables that fall out for patient and graft survival. So it's constantly changing.
But I guess what I'm wondering is you're measured against other transplant centers. It's, so that if somebody else is gaming the system, that the other transplant center is getting an advantage over your transplant center, and you could be penalized because of that. Is that correct? Or is it just everybody gets over the 97% success threshold and some get...
No, it's all indexed to the patients that you transplant and what risk adjusters are coded for those patients in your center. So everybody's transplant center has different expected patient and graft survival outcomes based on the risk adjustment that they submit for their patients. So there's not a curve, there's not a bell curve, and it's not a single threshold for everybody. It's relative to every single center.
So, all right. Well, then it doesn't. So it is what I'm wondering where the pressure comes if another center cheats or games the system. Where's the pressure on the center that's following the rules?
Well, not all outcomes for patient and graft survival are foreseeable or avoidable. And so if the idea is to fall within expected outcomes, the idea, a true accurate risk-adjusted patient and graft survival would take into account all of those factors and all of those avoidable factors. But, we only measure the ones that we can, measure. We can't measure the ones that we can't, and not all of them are foreseeable or avoidable. So, if we end up transplanting patients who have risk factors that are not otherwise measured, we're not going to get, transplant centers who do that are not going to get quote unquote credit for that. They'll only suffer the downside if those patients, or a sufficient number of those patients, don't do well. The other thing is, if a transplant center takes on even measurable risk, they have to do a certain threshold number of transplants that are higher risk in order to get credit. For example, let's suppose I do a series of kidney transplants with an expected graft survival of 80% at 1 year. I mean, those would be considered fairly high risk.
Right.
I'd have to do at least 10 of those, and 8 of those transplants would have to make it a year. Because if 7 made it, well, then I'm below the expected. To really get the full benefit of risk adjustment, you really have to do a large number of higher risk transplants and do them very well. If you only do 3 or 4 or 5, and one of those doesn't work out, you're not going to get credit for that. And then you have to take into account the vicissitudes of chance. So I think we've actually swung back the other way now. Medicare has actually come around and realized that their initial approach to risk adjustment was too risk prohibitive and resulted in risk avoidance on the part of a lot of transplant centers. So, I mean, to their credit, they really have listened to the transplant community and readjusted their metrics for flagging. So I think we're coming back around to a happy middle. And in addition, UNOS, United Network for Organ Sharing, and HHS, Health and Human Services, are now collaborating on a pilot initiative to single out particular transplant centers that want to take on higher risk organs and higher risk patients on a pilot study with some provisions for not getting in a lot of regulatory trouble for adverse outcomes, to try and find centers who can do these kinds of transplants well, and then teach others how to do it well. So it's not, there's some light on the horizon. Things I think are getting better on the regulatory front, and I think in service to patients and in interest in trying to increase appropriately transplantation without taking on too much risk. So I think we are coming back around to a happy middle.
I guess I'm just not so I'm trying to think if you had these 10 people, let's say, who by most ideas would have a lower chance of success, so call it 80%. Where's the risk to the system if they were put through? What's the break on that? I mean, you're using up 10 kidneys, but even if they were living related donors. I mean, you mentioned to me in an email that there's a lot of capacity. I mean, just as far as ability to do transplants. So
sure.
if those 10 people did go through the system, and let's just give me the benefit and say they were all living related donors, and so 2 of them didn't make it, or 3, and why? And there's a cost, obviously, but does it have to pencil out as a savings, or where's the? I understand risk to the individual centers performing it, but why is Medicare so keen on making that so, or is that just inadvertent?
I think the historical reason why Medicare got very interested in transplant center outcomes, in my view, was a result of some investigative reporting that transpired in the late 2000s. Some newspaper stories looking at regulatory oversights in some transplant programs that resulted in patient harm. And I think as a result of that, Medicare's attention was turned toward outcomes in transplant centers and tightening regulatory oversight of transplant centers. I think that
kidney space, kidney transplants.
It was in kidney and in liver. Charles Ornstein, who now writes for ProPublica, used to write for the LA Times, had some pieces in the late 2000s about there was a transplant program in California, I believe, that had a number of patients on the waiting list, but their transplant center personnel wasn't up to. Sorry.
Yeah, and now I was like, I blogged in the late 2000s. Where was I?
Yeah,
I'm remembering, but it seemed like, yeah, there was a problem with listing and
yeah.
people jumping the queue is what how I remember it, but I could be wrong.
I think it was
Um,
something. Yeah, there were a couple of different stories along those lines, but I think it just caused Medicare to turn their comprehensive regulatory attention to transplant centers and ensuring not just that waitlist management was on track, but also outcomes were on track. And I think it had, and I think they think it had an unintended
yeah,
consequence in terms of risk aversion. But as I said, I think we are coming around to a happy medium. But to answer your question, if we didn't have a supply problem, that is, if
right.
we were growing kidneys,
Sure.
the question would be we would have a different but a still interesting question, which is if we could get a kidney off a shelf, as it were, and postulating no harm to anyone else for just getting a
Right.
kidney off a shelf. The next question would be, well, are there still groups of people who perhaps would not benefit or should not get a transplant or would not be best off with a transplant? And I think the answer to that has to be yes. It's
Sure.
just that we haven't really thought that through very well because that hasn't been our most pressing problem. Our most pressing problem has been supply, making sure that people have access to transplant in a timely
Who
way.
wants them? Yeah.
Uh, yeah, but no, I think look, even if we got to the point of breakthroughs with CRISPR and Xeno or something like that, um, dialysis would still have a role for some people and should. I mean, when I evaluate people for transplant, Bill, I often run into patients for whom I think transplant is risk prohibitive. But I take that opportunity when I think it's clinically appropriate to have a conversation with them about home therapies. Because if somebody is sufficiently self possessed and interested in directing their own care to come see me, take time out of their life and come see me about a transplant, well, I want to make sure that they've actually heard about all of their options. And I think that this may be unfair to my transplant brethren, but I think that there are a great number of people like me who are transplant nephrologists who don't practice general nephrology and who don't take care of people who are using home therapies, such that it's just not on their radar. That's something that's very important to me. That there's not a unitary answer to what an appropriate renal replacement therapy is for someone
No.
at any given time. Somebody may have a transplant, that transplant may stop working, and then they go back to dialysis, and then there's another conversation about what type of renal dialysis modality is right for them, and then whether another transplant is right for them or not. I don't ever presume to know the answer to that question, and I'm not impressed that Kaplan-Meier curves, survival curves for transplant, are a robust answer to that question across different individuals. I mean, I try and always sort of go into it with an open mind. But I'm a big fan of home therapies
Sure.
too, and so I mean I'm sort of primed to have that conversation for people, even if they are a candidate, but they don't have a living donor. If they're looking at years on the waiting list, nocturnal home hemodialysis sounds like a good option.
It's just much less burdensome for sure. And I
Yeah,
think that's the terms I try to use. And then of course there's the health benefits, but it's the day to day burden is much, or week to week burden, I guess is how I would say it, is less. We're coming up on 30 minutes. Do you have a few more minutes to keep
I
talking?
have all the time you need. I can talk for an hour if you want.
Well, because you brought up, this idea, oh, you can't possibly imagine that every single person would want the same treatment or should have the same treatment, transplanter. But 90% of the people who aren't doing home therapies, or the 90% of the people, yeah, who aren't accessing home, they're doing conventional in-center dialysis for basically the same dose, uh, and I have an idea of why I think that's true, but I'm curious. How do you see that? I mean, how does that make sense to you that this is around the world? This is not some
Right.
pathology, of any system, So it's and I don't think
Yeah.
we feel like it's really meeting everybody's needs. So,
Right.
and if you, I assume, needed, just from what you just said, if you needed dialysis and couldn't have a transplant, you would pick a home therapy for yourself. So there's a dissonance there, certainly, and I'm always curious what your theory of the situation is.
I think it's some of it is socialization not only of patients but of physicians.
Yeah.
Some of it, I think, is a lack of training in and experience with home therapies. I think that that's a flaw in nephrology fellowship training programs, is that home therapies are not as emphasized as they could be. There's not as much exposure to home therapies as there could be. I mean, I was very fortunate. I went to my fellowship training was done at the University of Alabama in Birmingham, and they have a robust home program. And so I had an opportunity to be exposed to that. But there are, I think, a number of nephrology programs that aren't. And so there's, to some extent, the conversation with patients about their options is going to be driven, at least in part, by the nephrologist's comfort level with the therapies that they're offering to patients. I think that there is a certain ease of doing 3 times a week in-center hemodialysis. So when I have conversations with patients about home therapies,
Ease
one of
from the doctor's point of view too.
well, sure, absolutely, but also ease from the patient's point of view.
Oh yeah.
But one of the conversations or one of the responses I frequently get when I talk to patients about home therapies is that with an in-center schedule, dialysis is over here, and the rest of my life is over here.
Compartmentalization. Yeah.
Exactly. They compartmentalize dialysis as this is something they do, kind of like going to work. I go to work 3 days a week, and I'm there for 4 hours. Well, it's more than 4 hours. As I point out to them, it's actually much more than 4 hours. There's the transit time. There's waiting in the waiting room. There's getting hooked up. There's the needles. I mean, it's more like 6 or 6.5 hours for many of my patients.
And then wash out afterwards.
Yes, right. And then, the refractory phase for however long that lasts, and that's different for everybody. But yeah, I find a real reluctance that I find challenging to penetrate of getting past the issue of separating dialysis from home. I mean, I try, again, easy for me to say, I'm not on dialysis. I try and redirect that to, no, this is actually gives you more options. It's empowering. You can take control of this therapy and use this as a resource and a guide. But it can, especially if folks have been started on in-center 3-a-week dialysis, it can be hard to break out of a certain comfort zone that affords patients. It's what I found.
You forget what feeling well feels like. You get used to it for sure. I was in center 11 years, so I will remember. I worked and volunteered, but I also threw up a couple times a month. So, so I'm a little curious. So, yes, I obviously agree home, but why is it home or inadequate in center? So it's like, why is that the line? And in order to cross that line, it really does, and I think it's true. The way it's set up right now, it's set up. It requires the person being dialyzed to really take some initiative, or someone in their life to do that. And why isn't it sort of default? I think we can imagine other ways to do it, but how is it that we're so locked into this 3-day a week? And I call it a rut. I mean, I think if you've read my blog, I'm a fan of the idea of every other day, for instance. It just seems like
every other day dialysis is a great idea. I think especially
why is that a bridge too far?
It's not, in my view. We agree on that. I think so. This is a challenge, an interesting sort of philosophical question for someone committed to patient-centered care, which is when is patient-centered care breaching or infringing on a patient's autonomy if it involves nudges, sort of a kind of behavioral economics approach or choice architecture approach, where options are presented to patients as a default. So your options, Mr. X, are every other day dialysis or peritoneal dialysis or home.
Or
and
transplant.
yeah, there's this inadequate 3 times a week dialysis, but you don't really want that, do you?
Yeah.
I mean, once people, I mean, what I find is, I mean, I end up having conversations with patients about 15 minutes on a dialysis machine. You know, that this for some patients, this is, it's a big deal. Another 15 minutes,
Oh, yeah.
change dialysis prescription. And again, I try and be sensitive to the fact that I'm not on the sharp end of the needle, right? So so long as I can explain
use that too. I mean, we can say, hey, you know, it's like
that's right.
you don't have standing somehow to make that comment because you're not sitting there. Where I think someone has to say that, and
Sure. Well, so I mean, I try and split the difference when and where I can. Be respectful of that, but also offer them, my considered opinion of what I think will be better for their long-term health. So, listen, I struggle with it, and I'm open-minded and willing to learn as to how to improve on it.
I mean, you're a medical director. I've been involved with the governance at NKC. I think but I couldn't get it done as board chair. I couldn't get every other day trials anywhere. I mean, and so I know just because you're in the same world I live in that I don't think you could get that done tomorrow either. Just by force of will.
I know I could.
Yeah.
Not by force of will. It would have to involve regulatory and reimbursement changes too,
and
which
so,
I'm in favor of. I don't know anybody who's against that.
But it
really.
Just seems like no one has any agency. It's like, well,
yes.
What are you going to do about it?
Yes. So you find agency where and when you can find it, which home therapies often affords.
Again, had a technical glitch there. Sorry about that, Ben.
No worries.
I think we were talking about how, just the not having any agency to actually implement a change, like a fundamental change, like the changing the number of treatments per week routinely offered in center, and I guess one of the things I'll just put out there is that I worry about home dialysis being a kind of a cop out. Like we don't have to concern ourselves as much with the fact that so many people aren't getting a treatment we think is right for them, because they could do this, they could have this, you could choose that, and I know that some people just they can't do anymore, or they're doing all they can, and what it just seems like. Maybe we'll talk about this some other time because it's a big subject. Is that we don't really know what dialysis does, right? I mean, we don't know. We have a random distribution of pore sizes inside a filter, and things come out, and I feel better. Yeah. But I can control my potassium, I can control my phosphorus, I can control my fluids, and in 3 days I'm gonna feel like I'm dying slowly because something isn't. Your remic milieu. So it's I just don't. We shouldn't be satisfied with the fact that home hemo nocturnal, particularly, that works. It works well. I'm starting to see impacts of 30 years of ESRD, but I think I would have, if my transplant had worked the first time out in 1988, I could well still have these impacts after 30 years. Or others, certainly. So, so it's just, I feel like we need to do more for the people in center that we don't think are doing as well as they should be able to do. And if
Yeah.
and we shouldn't just say, well, you could do better, you could do more.
No, you're right. You're right. Uh, so I don't know. You and I to
Yeah,
the barricades, Bill. I mean, I'm ready.
yeah,
You
yeah,
know,
right.
I'll sign whatever petition and write whatever letter you want. I'm in favor.
Well,
Uh,
I think what I'm hoping too is talking about it.
yeah,
Is it's like if you have a little problem with your car, it kind of bugs you, but you don't realize everybody has the same problem. I think it'll help if we do kind of give it voice and talk about it. And I think there are things we can do to improve the situation, but there are the big challenges that I'm at a loss for. So, but we do agree that transplant is a great choice, a good first choice. Um, but these new cost models should accommodate aggressive transplant policies, I guess is how I'd say it.
yeah,
And we didn't talk about CKD at all, so maybe we'll have to do
right.
that another time too. But
Yeah. Well, just a little piece of CKD. So one of the projects that I've gotten quite interested in, and it's driven by one of my nurse practitioners who both rounds in an in-center dialysis unit and also rounds in our transplant clinic, is making sure that patients who have kidney transplants that are failing get transitioned back to dialysis in a safe way with permanent functioning access.
mm,
Because right now around the country, that the rates of transitioning back with a functioning graft or fistula are under 30%.
wow.
So it's something that she and I have really worked on very diligently in our clinic to both educate patients about their renal replacement options. Some of these folks were previously on home therapies. Some of them were preemptively transplanted. I mean, they all sort of come to this point from different avenues and different paths, but to make sure that they, just to my mind, somebody who has successfully maintained a transplant for a long period of time is a great candidate
Yeah.
for home therapies. By definition, they've shown that they can flourish autonomously. So why not pitch them this? And we've been fairly successful so far. We published 2 years worth of data in Nephrology News and Issues, and our rates of permanent access were about 80%.
Oh,
So
when
uh,
they're at first treatment, at their first treatment.
yes, functioning permanent access, either tank off or graft
Blood
fistula,
access,
mostly
yeah.
fissulas. Yeah.
Yeah.
So still
It
working
can be
on
done.
that remaining 20%.
Yeah, but one of the things in your paper, it seemed like, but maybe I didn't quite understand it, was it seemed like it imagined casting a pretty wide net for people with pre-dialysis to
Yeah, right. So, the missing piece in all this is chronic kidney disease. The patients who are in a general nephrologist's office who are considering all of their renal replacement options. Working that out as a financial model is a little more complex, but I think it can be done. And I think the next step would be integrating nephrology practices with who have a large patient population with advanced chronic kidney disease into this model to try and increase rates, at least of preemptive referral, if not preemptive transplantation. As you pointed out earlier, preemptive transplantation has gotten a little bit tougher with the new kidney allocation models that really
cadaveric, yeah.
yeah, right, which really privilege patients who come to the waiting list with many years of dialysis time. But it doesn't preclude the possibility of preemptive living kidney donation. And I think there's clearly some opportunities there. I mean, I should probably plug to my co-author in that paper was Frank Maddox, who's the chief medical officer of Fresenius Medicare North America. And I think that is at least some evidence that Fresenius is quite interested in expanding their presence in transplantation as well. So.
Yeah. Well, it's but just one part of the CKD piece. I'm not sure is if everyone really knows how many people have CKD4 versus how many actually transition to CKD5.
Right.
That's the problem, right? I mean, if everybody who had CKD4 was destined for dialysis or transplant, but for something else in a shorter time frame, I guess is how you'd put it.
Yeah.
Then it would be an easier problem. But people can just be there for a very long time, right? And,
Right. And you can have somebody who's 89 years old with a creatinine of 2, and they are CKD4, but they may have had a creatinine of 2 for 20 years.
yeah,
And a transplant's not going to help them,
right.
or probably is not going to help them. So, I think we've always got to be vigilant that any of these models are going to have unintended, undesirable consequences. The idea behind the model is just to make sure that patients get appropriate education about their options, including none of the above. Perhaps, for that particular patient, it might be especially important to say none of the above,
No,
and make sure that,
choice.
that those are not, that patient-driven choices are not unintentionally disincentivized by some bug in the model.
Right.
So this is just sort of the first iteration. I think I've sent this paper around to a lot of different folks, really looking for critical feedback, because I don't have all of the answers, and I'm sure I know I haven't thought of everything. It's just the nature of complex models that nobody's going to think of all the permutations. So
Absolutely.
the hope is that this is the beginning of a pilot that we can revise and build on and learn from as people offer some comprehensive feedback. But
I know there's a lot of energy in the patient community about CKD. I mean, it's easy to understand that the motivation of not wanting anyone else to experience this. So, but it's a complex problem, population health. So
yes, yeah.
So yeah, everybody just needs to move around more and eat better. But
Yeah, simple as that.
So, well, thank you very much for joining me for SEN Talk. I think there's plenty of other things we could talk about. I need some transplant perspective, and there's probably also areas where we can hash things out that we don't quite agree with about. But I'll look for you on the barricades in the meantime. And
That sounds great.
And
well, Bill, I just want to say I have really enjoyed and recommended your blog over the years. There aren't enough people like you out there who are writing about this and talking about it, and rattling our cage. We deserve to be provoked, and in the best of ways, because it makes us better. It makes us think about the way we've always done it and whether that's the right way to do it. And I'm very appreciative of the time that you've taken for all these efforts, and I've learned from it. So thank you.
Well, thanks. That's a great compliment. So I appreciate it, and appreciate your long time readership. So it's
anytime.
Good to talk to you. And I know you've bumped into Anna, my co-blogger, at conferences on occasion. So Becky. So I'm sure she gives her regards as well.
Yeah, great.
All right.
Well, thank you again, Bill.
All right.
And I'm happy to pick this up again anytime. Take care.
Excellent. Thanks. Bye.
Bye.